There's really three main methods for transporting carbon dioxide. The first one that I'm going to talk about is physically dissolved in either the cytosol of the red blood cell or it could be in the blood plasma itself. It's important for me to note that both of those are aqueous, which means it's a water solution. And so that is why that carbon dioxide can dissolve. It's because carbon dioxide can actually quite easily dissolve in water. So if we look here, the yellow in this diagram, if I grab my pen here, the yellow out here is the plasma. And then we have two red blood cells. Maybe we shouldn't have red pen. We have yellow. Those are my two red blood cells. So we can see both of them are going to have some dissolved carbon dioxide. There's also some dissolved carbon dioxide out into the plasma. And we see this up here at number 1. So again, physically dissolved in either the cytosol, the red blood cell, or it also could be in the blood plasma itself. The second one is bound to the globin portion of hemoglobin. We see this at number 2 in the diagram here. So here in number 2, carbon dioxide bound to the hemoglobin protein, and that can be transported via that globin portion. And then number 3 is the most prevalent form, and that's going to be through bicarbonate, and that again can be either in the red blood cell or in the plasma. So here we have a bicarbonate atom, and it again can be formed also out in the blood plasma. So I'm going to get into each one of those individually in this presentation. So we'll start with physically dissolved. All right. So carbon dioxide is very soluble, as I mentioned, in an aqueous solution. We can have this in 2 spots. We can be in the cytosol of the red blood cell as well as the blood plasma. So in this diagram, I have some dissolved carbon dioxide here, and there's also some dissolved out in the blood plasma here. I do want to just point out off to the right side, what I have here is a muscle cell, but this is really just symbolizing any tissue in the body. So what we have is carbon dioxide being created, and it's moving out of those tissues into the bloodstream. So out here would be plasma, and then in here is my red blood cell. So about 10% of the total carbon dioxide that is found in the blood is going to be physically dissolved in either the red blood cell, cytosol, or out in the plasma. And it can be transported in both of these spots. About 6% is found in the plasma, and about 4% is found in the red blood cell. Again, 6% can be found here, 4% found here in the image. And that's not an exact always figure. It's, again, a rough approximation, a pretty close estimation there. So again, that's the first type, physically dissolved carbon dioxide in either the cytosol or the blood plasma itself. Okay, number 2 is bound to hemoglobin. And in this case, we have about 21 to 30%. Again, that is depending on where you go. If you look at this specific diagram, I'll show you, circle it here. It says 21. Other locations might say up to 30% of the carbon dioxide in the blood is bound to hemoglobin. So statistics do vary a little bit, but about 21 to 30% of the carbon dioxide found in the blood is bound to hemoglobin within the red blood cell. Again, it does bind to that globin portion of the hemoglobin, and it does travel. Again, this would be within a red blood cell. So again, we have the red blood cell here, and that's going to be here. I have my hemoglobin, and that's going to be where that carbon dioxide binds. Okay. And then the last type, by far the most prevalent way that carbon dioxide transports in the blood, is through bicarbonate. And bicarbonate can be found both inside of the red blood cell. I'll show you that right here. So this is carbonic acid dissociating into bicarbonate up here. And then it also can be found down in the plasma, being, again, we have carbonic acid dissociated into carbonic or bicarbonate here. Uh, so let me just talk a little bit more about this. As it's the most prevalent form, there's a little bit more information on this one. So about 60 to 70% of the carbon dioxide can be transported via this system. It can be found again in either the red blood cell or the blood plasma. If we go with that upper range, 69 to 70%, 64-ish percent is synthesized, or of this bicarbonate is synthesized within the red blood cell. And this would occur via reactions with water. It would combine with water and form carbonic acid. But this reaction, you'll notice, is catalyzed by an enzyme called carbonic anhydrase. And this catalyst, this enzyme catalyst, makes this reaction happen quite a bit quicker, which is why we make a lot more bicarbonate out here, or in here, I should say, in the red blood cell. And that's just, again, due to this enzyme carbonic anhydrase, which catalyzes or makes this reaction happen quicker. Once we have created, what we have here is carbonic acid. Again, that will dissociate into hydrogen ions and bicarbonate. When we have bicarbonate, through chloride shift via the chlorine bicarbonate exchanger, known as AE1, that bicarbonate leaves the red blood cell you see here, and it enters into the plasma. Again, it is important to point out, though, that it was synthesized, or it was dissociated from the carbonic acid within the red blood cell itself. And that's really important, that it actually does leave the red blood cell, because it allows that red blood cell to make more of that bicarbonate. The other part down here is out into the blood plasma. So some of this bicarbonate can be synthesized out in the blood plasma itself. Now you'll notice that it says that this is slower. The reason why this is slower is there's no carbonic anhydrase out in this blood plasma. So there's no catalyst to make this go faster. So it does happen. You'll notice it's only about 5%. But again, it does occur, just much, much slower in comparison to the process that is going on within the red blood cell. Okay. So again, but the process overall is pretty similar. We have carbonic acid dissociated into bicarbonate and hydrogen ion. All right. I wanted to just point out this image here, which shows at the lungs. So over here on the right side, we have the lungs, and what you'll notice is all of these arrows are going in the opposite direction. But the key part here is what's happening with carbon dioxide. So all of these carbon dioxide, whether I look at the hemoglobin, the bicarbonate comes from here, as well as here. All of this is eventually entering that lungs, where it can be exhaled from the body. So all of those reactions that we just went through go in reverse at the lungs, so that carbon dioxide can be expelled. And there's a particular effect that really allows more carbon dioxide to be expelled from that lungs. We call that the Haldane effect. So the Haldane effect is associated with the carbon dioxide that is bound to the hemoglobin. And at high oxygen levels, like those found around the lungs, oxygen is going to want to bind to hemoglobin. When that happens, it destabilizes hemoglobin, and this actually causes more carbon dioxide to unbind from that hemoglobin. In the graph here on the right, we can see that the blue line is associated without the Haldane effect, and the red line is with the Haldane effect. So the key part here, If we look at without the Haldane effect, only about 2 milliliters of that CO2 is released from that lungs. But with the Haldane effect, we get double that at 4. So this Haldane effect is very important because we have essentially double the amount of carbon dioxide being able to be expelled from that lungs. And at lower levels of oxygen, so opposite of this that will happen with at lower levels of oxygen, which would be at like tissue cells. More carbon dioxide will actually bind to hemoglobin at low levels of oxygen, which is going to allow our tissues to get rid of that carbon dioxide. Can again work in reverse. Without the oxygen there, more carbon dioxide can bind, and with the oxygen there, less carbon dioxide can bind. And that's really the Haldane effect, which allows more carbon dioxide to be released from our lungs. All right, so now just getting into my journal article that goes into carbon dioxide in the blood and really when we want to research this and when it can become really important to track this. I looked into a study that looked at different methods or techniques to measure partial pressure of carbon dioxide or alveolar ventilation. Examples of some methods that can be used to do this are blood gas analysis, capnography, and transcutaneous measurement. The image I have on the screen here is a transcutaneous measurement device. The top, I know it's really small, but the top measurement in this device, if you look in the green here, I got my pen, right at the top, it says partial pressure of CO2. In this case, it's at 37.6. And then it just shows that this would be attached to the body. You can see when attached to this baby here. So that, again, wasn't just an image of transcutaneous measurement. All of these techniques, it is important to point out, can be complementary of one another and can be used combined with one another. These measurements are very important in a clinical setting. When looking at a respiratory failure, for instance, we also can look at CO2 transport. We can look at resuscitation and sedation as well. Blood gas analysis is considered to be more invasive. It's an invasive technique. It also can be quite painful to the patient, but it also is considered to be the gold standard because of its accuracy. Capnography is non-invasive, and it measures expired CO2, and it can be recorded continuously as part of a ventilator circuit. And then the image here, we have the transcutaneous measurement. It is also non-invasive, just like the capnography, and it uses those skin electrodes, and I pointed that one out on the baby. So it has skin electrodes, and the CO2 diffuses from the tissues within the body, and it diffuses to that electrodes where it can be measured. And the nice thing about transcutaneous ones is that it can provide trends. All right, so if I get into some of the images within the art journal article itself, what we have here is this is using the transcutaneous method. So here we have a graph that is going to track the partial pressure of carbon dioxide within a patient at two different body positions. So we have the supine and the lateral position, and we can see how that might affect the partial pressure of CO2. We also have a couple things that were noted on this graph, so I'm going to point those out. Up here, we have a change in the mask. So we went from a nasal mask to a full face mask, and then we have an upper airway obstruction here. We can see following that upper airway obstruction, partial pressure definitely decreased down. So that's one method. So again, this graph does a really nice job of showing the progression, though, in this patient of the partial pressure of that CO2 within their tissues at these different electrode sites. In this next graph, we have overnight trends were tracked in this particular patient. And this particular patient suffered from congenital central hyperventilation syndrome. And you can, again, this one does a nice job of showing how these can be used complementary to each other. So we have the red blocks, point those out. These red blocks are ABGs, which is just a denotation for a blood gas analysis. So we have one here, 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 and also here. And then the other one that was used for this is the transcutaneous measurement. And again, we did an overnight trend with these. Capnography is not ideal in this case because oftentimes we'll have mask leakage, which can lead to inaccuracies. So that's why that one was not used. Transcutaneous works well because again, we're going to show those trends. And then we use these red boxes because remember, that's the gold standard. The weakness with that blood gas analysis is that we're not getting that overall trend, but it can be used really well to basically confirm the data that we're getting. So we see these red blocks, for the most part, are really close to our line, definitely within statistical significance here of the line. So essentially, that blood gas analysis was used to confirm what we're seeing here with the transcutaneous measurement. So just a good graph showing how these can be worked in concert with one another. And really, we can use both to kind of confirm the other. All right, so I do want to just hit some results or the summary, essentially, of this journal article. These techniques they found very useful in the clinical setting, especially with patients with respiratory failure, where we wanted to track them over time. Each of these three techniques have strengths. They also have some weaknesses. I mentioned some of those, and they should be used appropriately to fit their strengths and also be used together because they can be very complementary of one another.